So, hello everyone. Thank you for joining us. My name is Abna Poku Ewuku, and I'm an advocacy manager at the Medicines for Malaria Venture. Today promises to be a very exciting session. We have a great lineup. I'm being joined by my co-moderator, who is Professor Jean-Louis Ndiaye, and he is from the University of Thiès. So he's right next to me in the picture there, and he's a professor of parasitology.
Thank you, Abena, and good afternoon, everyone, which will be tackling how to sustain digital tools while using the example from a country perspective. We will start with three speakers. We have Professor Aurore Oguye Mihuntu, who is a professor of parasitology and who is also member of the African Parasitology Association, and she is also a former NMSP coordinator, and she has been fighting also malaria. We have also Professor Eugène Lama, who is a project manager for countering malaria in Guinea, and he's specialist in national health and immunology, and he worked in various services before joining the national program, where he's doing a great work. And finally, the third speaker will be Jiko Bondole from PATH, who is monitoring and in the MNT program, that is the neglected diseases.
Okay, so we will begin then with Professor Ore, who will be speaking with us about her experiences in Benin. So please, Professor, over to you.
Thank you very much. I would like, first of all, thank the organizers and the partners for the opportunity that is provided to Benin to share experiences in the use of the ICTs for the ITA-SFC in terms of challenges and lessons learned for the sustaining and the pleading and the advocacy. We are going to make presenting it based on the following agenda. And as an introduction, we can say that the mass campaign is based on distributing to all the population either medicine or mosquito nets. This campaign has been implemented in various years. We had also the campaign, digitalization campaign aims to use ICTs on the process for the training of agents until the distribution. Benin has tried the mild campaign numerization in 2020 and had two CPS campaign digitalization campaigns. I think that there are various advantages of digitalization, and I don't need to tap on that, and we will discuss it during the discussion, and it's not the topic of my presentation. I would like to underscore the advantages we can see it during for the training and do the census, the distribution, and the payment of the various actors, and stock management. Now we move to discussing the challenges. The first challenge is to be able to effectively take stock of the situation during the training. The digitalization allow us to check the agent at the entrance and at the exit of the training, but the time is not timed. It will be good to have the time spent by the agent on internet. We have also the challenge pertaining the continuous operation of the platform during the implementation. We can have an overload of the platform while taking into consideration online saving difficulties. We have the coverage. Internet coverage is an issue. In order to synchronize data in real time, we know that our campaigns are all sometimes done in remote areas, and if there is no coverage, that's difficult. And if we need to do a national campaign, we need to cover all areas, but we need also electricity and gas coverage too. Another challenge is the identification, fraud identification. So this tool help us to show if there is any issue or a fraud on the medicine virtual administration. But the problem is that we cannot know what's the problem. If we have the tool, we can be able to diagnose the lack of medicine through the CPS, who received the medicine, and if the medicine has been administered. Another element, we do not have enough technical agents in the villages. We work in remote areas, and in order to handle the digitalized tool, we do not have that experience, and it's very difficult to find this expertise or find people who can manage the tool in remote areas. Another problem we are facing is the rigor in selecting the agent. For example, the ID card, the mobile number, and that once again it's the same issue we are facing in remote areas. Most of the time, the agents who are recruited do not have an ID card. And the last challenge is we do not have enough money, enough fund to lead this tool, this digitalization. What are the lessons learned? We understood that we need availability number of power bank, solar power bank. We need also CCTVs, and you need once again our campaign are taking place in remote areas. We have some information that are not disseminated and do not reach these areas in real time. We need also we plan also to start the campaign as soon as possible. The close supervision to monitor the agent to avoid bad practices, and that is done through the provision of SP data and coverage data in real time, but also through the use of the dashboard, which is the platform that helps to gather information and to share information in real time. We have also the necessity to have some technical agent, additional the technical agent who can help. As you should know, also the agent. Another lesson. So, for example, if the agent cannot come to work, we should have the opportunity to replace him by someone else. What that the campaign can be affected. We need also to have health system agent who need to be involved throughout the process of the digitalization. Currently, the legislation, we need to implement health system agents. We need to test the tool before in the implementation in order to correct some mistakes or some issues or glitches that may happen. We need to have a daily debriefing that have to have a daily feedback on about the non-covered areas or the let alone areas. Another lesson learned is that the name writing of the beneficiary is a problem. We need the insurance that the smartphones are synchronized before the beginning of the campaign, and all the agents need to start the work at the same time. Most of the time we do the synchronization before the night before, and we start the day after. In perspective, we think that taking the digital fingerprints can be beneficial for the beneficiaries and can help some issues like the fraud and in medicine distribution, and even when mistakes happen for the names. We need to have a geographic coverage by internet in order to sustain the tool. What is the perspective? Our perspective: sustain campaign, digitalization campaign. We want the digitalization to be a tool for mass campaign, and countries must show will the awareness of the partners pertaining to digitalization advantage, and we have to integrate campaign digitalization in the national health system in order to reduce the costs and to mobilize financial resources. In conclusion, we can say that digitalization is a tool that allows to improve and to make viable mass campaigns. It is an innovation that is facing various challenges, and the resolution of those challenges is necessary to use them in the campaign. Thank you for your attention. Thank you very much. Thank you, Aurore, for this great presentation. We can see the challenges, but we see a lot of lesson learned, and we see the success of this campaign. We're using with the CPS. We're using the digital tools. We're moving to the second presentation. The second presentation will be made by Dico Bondele, and who is going to talk about the use of the TIC, the ICTs in the Republic of Congo. How can they be integrated within a program? How the Republic of Congo can scale up the use of this tool, and how can they use this digital tool to ensure a sustainable outcome. Dico, the floor is yours. Thank you very much, and for giving me the floor. I would like to thank the organizers for thinking to the DRC to share our experience regarding the sustaining digital tools based on a national perspective. So in this presentation, we are going to discuss three topics. The first one is is it easy to use these digital tools in DRC, and how DRC is going to integrate the data between the programs, and finally how DRC plan to develop and sustain the use of these digital tools. Beyond the adoption of digital health that has been adopted in DRC in 2014, up to now, the country is still in the pilot phase. Various projects use the digital tools and collect data like Conquerors, Serveto digital tool, Odike, and EOS, and all these tools are limited to in scope and the duration of the project. Though those tools are used, there is still two dimension: the quality of the data and the overall effect of this data, and that is due to the lack of experience and expertise of the agent. Through collaboration with partners and with the countries, the PNLP and the emergency centers were able to use the dashboard in order to cater the needs of the country when it comes to analyzing the data when it comes to malaria, and to improve the quality of intervention in countering malaria. This dashboard is still in the pilot phase. We have stakeholders at national level, and the Ministry of Health are autonomous in using this dashboard, and the country has triggered the dashboard use in Okatanga province, where all the Ministry of Health officials within those provinces have been trained on using the this dashboard. And the feedback are very positive regarding the data analysis and decision taken. Regarding the data integration and the collaboration with technical and financial partners, this allowed to the development and the adoption of the DH2 in the database, and that is used as health. This dashboard has been deployed in the health system. That means we have 519 zones where managers can disseminate the information and receive data. It is important to mention that with the country we have the data integration platform, the DS2, like DS2, ACNR, and GITRA, which are connected to the ministry's health, and that helps to have a surveillance and to monitor the illnesses and diseases throughout the country. Regarding the sustaining this use, the President of the Republic considered that the digital development will help the country to move forward, and that is a part of the philosophy for the use of the digital tools while creating the Ministry of Digitalization and the National Agency for Digital Health since 2018. The country is starting a new era of digitalization. What we did is that we budgetized the roadmap for digitalization that will help in reinforcing digitalization, health digitalization in DRC. The country is setting up a new laws in order to improve the digital health in DRC. You have here in nutshell some national perspective in DRC regarding the sustaining digital health. Thank you.
So thank you very much, Jiko, for that great presentation. It was great to learn, how DRC is putting in place a strategy for digitization and how digital tools are also transforming data management in DRC. So we'll move on to our next speaker, Dr. Lama, who is the National Malaria Control Director, and he will be telling us about how Guinea is scaling up digital tools and is also using digital tools for malaria control and elimination. Over to you, Dr. Lama.
Thank you very much. Thank you very much. It is an opportunity is given to thank all the people who are supporting us on the ground when it comes to capitalizing our data and to have the experience of the other countries. In the framework, so the example of Guinea and the digitalization in countering malaria, it goes back since to 2016 with the prevention, with the lesson learned and the perspective and prioritization of countering malaria, and that was supposed to last until 2017. And now we tried with the partners check that we have also some tools on the ground, and we had also some difficulties, and the work environment was not so easy to do. On the other side, we needed to reduce this working room, so we made an experiment and we used a tablet in the sanitary health district. So we provided 17 tablets to data management. This data has been sent to the health establishment, to the GPS. So the health agent did not do the disseminate with the village. We kept doing so until 2021, and we tried in 2021 to experiment within the health centers, and in this time we went in the health district, mainly in the mining areas. We went not only to the health centers but also to the distribution within villages. With the tablet we had, we tried to parameter the CSS2, that means the capture the internet within the community. So that's how we are going to start the action plan. So first I will give you a background. You can see the digital interpretation, and we have the impact and perspective of those intervention and the lesson learned, what I've said, and the sustaining measures for and the scale up. So the CPS, as I said, because we didn't say it, we started within the health district. We tried to implement the DHS 2.2 with capture with the tablet. We did the digitalization of primary data based on the card and the cards within the health centers within the district. This helped us to know within the server how the campaign was taking place, but on the ground we were not able to see the progress of the distribution team of the CPS. However, we noticed that is a reduction of the working rooms. In 2021, as I said before, we went to a pilot district where we had various issues with the mining centers. We took 3 health centers. With the number of pilots we had 2 distribution, we gave 2 per team. This allowed us to reduce the time in work and to have the data in real time and to make a follow-up of those teams in the centers, health centers. There was a difference between those centers having tablets and those do not have it. However, with the DHS capture, the agent who was working wasn't able to see the coverage curve per day because this application didn't allow him to do so. In 2021, strong with all this experience, we decided to go to scale up the campaign with the Minda campaign. We tried to change the DHIS2 capture with a local platform that help us through the tablet not to have the information, which means to digitalize the data within the household with the distributors, but also to try and to see anything that is pertaining in real time, and following up our agent. This took time because somehow we needed to buy this year. We did have to distribute 9,000 mosquito nets. We need to use 7,000 Android in 38 health districts. So we needed to buy this tablet abroad, and setting them up took time. So we did this crescendo, and now we are doing the censoring. When it comes to perspective and impact, this improved the follow-up and the feedback and the supervision of activities on the ground. As I said, even those who are using the tablets, at the end of the day, they can sit and know what was the progression. At the same time, the supervisor in their district and Conakry follow the teams on real time when it comes to the sensing, because now we are making the sensing. What is the recommendation? So the productivity, we have an increase of productivity within household, and the people are responsible, are accountable, because now this allows the data can be to identify the person who is going to facilitate the distribution process. Now, when it comes to reduction of the management tools, we are using 6 management tools. The number of tools has been reduced that spare time and that facilitate and improve the stock management that we have on the ground. That reduce also the rooms use, work rooms, and we have also less overload on the supervisors and the teams on the ground. We need to have 3 supervisors on the ground. That reduces also the period of waiting time for the beneficiaries within the families. We know that a lot of things are happening, so that reduces the time for the families. The tablet takes less time. The beneficiaries wait less. We have an improvement, but also the data security is ensured even for the beneficiaries. These data allow us over time to make instantaneous coverage with the tablet. Here are the lessons learned. In terms of opportunities, we can see that the electronic coverage is good. The distributor, the agents, and the tablets and supervisors are connected and exchange in real time. They have to agree only on the planning. Currently, we have a local expertise in technology because everyone appreciated that and learned a lot. It is the first time that we did that in Guinea. And it is to mention that all the programs will benefit from this tool because at the end we will keep these tablets within the health districts. We experimented, so the pilot project that we did is Swako Sigiri helped us to achieve all the expectations. However, we have some challenges. The challenges at the beginning, the synchronization during the training. People who are taking the information because there was no internet, when when they have the information, they accumulate information and they cannot check all the information. We have then second issue is the maintenance of the. We set up a focal point within all the provinces to improve the maintenance. A third element, we have a third need for training from the regional level at the province, the health centers, and mainly within the distributors. We mobilized enough supervisors who have been trained and in order to disseminate the knowledge. In a nutshell, that's what we have. When it comes to the perennisation, we have, as part of the continuous training, we want to scale up the training for everyone.
The workload is easier, and so thanks to the experience, we also have a strategy for internet coverage. This is thanks to a partnership with telecom companies, and the server is used by a health system. It didn't previously reach the community level. However, with the tablets, we can go further within the communities in rural areas. This enables us to reach out not only to the CPS program, but other programs as well. So these are the measures that have been undertaken within this project. This sums up, in a nutshell, where we are at within the community outreach. Thank you for your attention. Thank you, Eugène, for this experience sharing in Guinea with regards to digital tools. So we've traveled between Benin, Congo, and Guinea to see how various anti-malaria programs are being carried out with various digital tools. Before giving the floor to other participants, allowing them to ask questions, we all agree that there are various obstacles. Please share specific obstacles and challenges that you are confronted with. So we all know that we're more and more to be using the DHIS system and some issues with interoperability. We can start discussing the major challenges you've been faced with. Also, you can also perhaps tell us more about the nature of the partnerships with community actors, healthcare providers, what was the reception or the reaction to these digital tools? Thank you. Eugène, you have the floor. Yes, I've already touched upon the challenges, perhaps too quickly. Basically, the availability of these tools is not always guaranteed. Partners don't necessarily wish to place orders to purchase new tools. So electronic tools wise, I said earlier that we initially used tablets, and there was a missing system at the time. This system allowed us to monitor and get informed about the coverage. And so I would say that the major challenges were at this stage. The interoperability with DHIS is crucial, and that is one big advantage that we do have. Now, when it comes to the perception from the community side, there isn't much to say so far, if not to say that we probably need to sensitize more, and we count on community mobilization within the health providers and the healthcare. For instance, we do need to communicate and guarantee the efficiency of enumeration. This is one area where we did not have any challenge. Aurore, go ahead. I think you wanted to speak. Challenge and difficulty-wise, I did identify a few. Yes, perhaps you can pick the most challenging aspects of your work. Yes, how to sustain digitalization? That would be the question. This far, what we're carrying out is very costly, and we cannot keep up at this pace, financially speaking, for much longer. So the health system at every stage can definitely integrate digitalization and work with a parallel system with various tools, various workers, and who would be trained to use these digital tools. However, if these health workers who were already recruited by a government have been initially trained, this would allow sustaining the sustainability of the project. Another thing is to be able to rely on real-time data provision. Aurore? Yes, go ahead, I'll let you finish what you started saying. Yes, interoperability, you asked. The platform so far wasn't fully connected. We are, however, working on this with a few partners on DHIS, namely, and just to say that we're working on it. With regards to the government, I would say that when it comes to digitalization, government should be used on any mass campaign with regards to health, simply speaking. And reference data were used on the 2020-22 campaign. Just to say that policy-wise, I think we're on point. And when it comes to health workers, they are burdened with paperwork. However, there should be means to perhaps lighten this aspect of their workload. And socially speaking, how to live with digitalization, that's another question. Yes. Thank you. Aurore, so you're saying we can make do without any paperwork in the healthcare system and basically rely on a centralized electronic database? Mostly referring to campaigns. It does sound risky, but it would depend on where you are. Perhaps it's feasible. Now, digitalization, when it comes to the health sector, you can't really go 100% paperless. Thank you. Gico will have the floor now so that we can have his inputs when it comes to the situation in the DRC. He's touched upon some of the policy. Thank you. For the DRC, as I had previously said, DHIS2 has been used at the health centers. Know that we're still very much paper-based. The major challenge currently, I would say, would be with regards to capacity of those workers, specifically those managing data. I believe there is substantial deficit in terms of capacity when it comes to program management, and this is one of the challenges when it comes to overall management and data management, including in the contexts and the rationale for the various programs. We would like to rely on not to better capacitated analysis and management to guarantee better data quality. Thank you. I see there are a few questions already popping up in the Q&A. I think you can directly answer to some of the questions before we conclude. A last question for you. How do you think that these digital tools at a national level can contribute to eliminate malaria? Thank you. Yes, thanks to the advantages of these digital tools, if work is made easier, and know that in our health centers, we work on other issues other than malaria. However, these tools, for instance, with the MILD campaign, which would take us 3 months, for instance, know that these programs take a lot of our time. So basically, these tools help us lighten our load and gain time. So these tools help us better monitor in real time, and again, shorten waiting time for all those waiting to get healthcare. This is very unmotivating for some, and so this would greatly improve the quality of the care we provide. This is how we consider that digitalizing our activities definitely has added value and will greatly contribute to eliminating malaria. Thank you. Gico? Thank you, Professor. To answer your question, we think that digital tools play an essential role. First off, to eliminate malaria, we do need available data with high quality to enable us to make the right decisions. Then on, allowing countries to access data when needed in real time, and perhaps also monitor the situation. For instance, within the DRC, we have an integration platform for data thanks to this platform, this data platform, we are now enabled to access all data in one platform, and this greatly facilitates decision making. Thank you. Aurore? Yes, thank you, Jean-Louis. I believe what I had in mind has already been said. So digitalization has a role, but no, let's remember that quality of data is an issue in our countries. And all the data, all the figures that we do use or see in various reports are yet to be checked. So digital tools can help us improve the quality of the data we use. So once we have the reliable type quality, the decisions that will follow and go into programs and interventions will be, of course, more efficient and go towards eliminating malaria. Thank you. Thank you for all these answers. I think we should now open the floor to hear back from the crowd, from the audience. Okay, let me ask.
I'll ask a few of the questions that are in the Q&A. I think one question that is coming out quite a bit is about cost and cost effectiveness. So have you conducted any cost analysis or cost effectiveness analysis between, the campaigns you're doing and then the classic campaigns where you were using paper? So I think I'll pass on the floor to Aurore first, and then we move on to Eugene and then Jiko.
Yes, there was a question for you with regards to costs. Have you carried out any analysis on cost? I wouldn't say so. We haven't made a cost analysis. We do know, and this is what I was saying earlier, we do take into account the cost of digitalizing, for instance. Now, I don't think I have the answer that would quite answer this question. We do know that digitalizing will be very costly. And as I was saying earlier, it all depends on how the setup is done. And when working on innovation in our countries, we do need to apply it across the board, across the chain. And the cost is still very high for now. Now, once we have digitalization within the healthcare system, I think we will eventually benefit from lower costs. Thank you. Can you perhaps also let us know in your estimates, when can you have a return on investment? You may not have a number in mind, but how many years do you think would it take for you to get, It all depends. Cost is about purchasing equipment, paying consultants. It depends what you mean by return on investment. What do you mean? Do you mean we'll reach a stage where any money spent on digitalization will no longer be an issue? Won't make any dents? Yes, once you've covered all purchases and payments on yearly basis. Many countries deplore the fact that the initial cost is too high. So how many years, according to you, need to go by before cost is no longer an issue and that we start getting a return on our investment? Now, I would say a few years. Depends what you've bought. And You will need a few years before talking about amortizing costs. The second year, first of all, whatever you purchase will cost a lot less than the first one, and so on. But it seems to me that digitalization costs will remain as high. And again, I'll say it again, it depends on those health workers working on digitalization.
Okay, merci, Professor. Dr. Eugene?
Thank you. We haven't per se have carried out a cost analysis, but however, looking at the opportunity costs when it comes to digitalization, we also take into consideration the time gained or the time that has been saved. Now, these tablets will also be used by other programs, not only for CPS. They will be used for other campaigns. For now, in terms of opportunity costs, basically numbers are looking good. However, when it comes to cost efficiency, we have yet to carry out such analysis. Thank you.
Okay, that's okay. I'll move on then to the next question. And it's about integration between malaria and other disease areas. So in terms of the lessons learned from, malaria, digitization for malaria, how do you see that being integrated with other disease areas? And how do you see that becoming, so to say, the norm for the country's strategy? So maybe I will start with Professor Oro.
Yes, thank you. When it comes to integration, I had said earlier that the Ministry of Health is planning on regrouping all health-related campaigns when it comes to digitalization. There was a pilot project in the PLMP and the program against transmissible diseases. Now, digitalization was used to distribute within the campaigns, and this has been a wide use previously. And the PNLP has made this available and so other projects are in the pipeline for those illnesses for which we administer various medicine. Why not? Vaccination campaigns as well. And so I think the integration is on its way.
Thank you very much, Professor. Jiko, would you also like to respond to that? Integration between malaria and other programs for digitization.
Yes, as I had said earlier, within the DRC, data collection is at an early stage within the project. Once the project is finalized, this is our main challenge for now. That being said, things are going quite fastly. Last March, the government adopted the budgeted roadmap to support digital health, and this was definitely a big step enabling the facilitation of digital integration.
Thank you very much, Dr. Eugene.
Thank you. We have already integrated this with our various programs, vaccination, maternal health, community health activities, including identifying children under the age of 5, including pregnant women. Last year, we also carried out a test, and this I had mentioned. So within this test, we tried or attempted to digitalize on our vaccination campaign. And with these tablets within the health centers, which greatly enabled us to better monitor. So integration with the data we already have within the 3 different programs. Thank you.
Thank you. So as we have 5 minutes, I will just pass the stage over to each speaker just to give their last word on how they think digital tools can help us move towards malaria elimination. So I'll start first with Jiko, and then we move to Professor. So moving from digitization to elimination.
I think you had previously asked how digitalization brings upon elimination of malaria. With digitalization, personnel will be more available, more welcoming with better services, and the health centers will provide better quality services. There will be more people seeking consultation and healthcare services, and this will greatly reduce the mortality rate. Secondly, on the quality of data. This is a serious issue today. Digitalization is a tool that will enable us to have better quality tools, reliable tools, and this will speak to the quality of our programs based on these data. The strategies that will be defined as per these high quality data will also be changed. And so mapping disease-wise will also be more accurate. And this is how digitalization can really boost improved and better quality strategies for more efficient responses.
Thank you very much. That was really useful. Jiko, if you're ready to take on that question.
Thank you. So when thinking of malaria elimination, the first thing that comes to mind is monitoring and surveillance of the disease, as well as the guidelines on the various response measures. Digitalization remains a key setting when it comes to malaria surveillance in order to eliminate malaria by improving quality. Thank you.
Thank you. So Dr. Eugène, you have the last word, and then I'll pass over to Professor Jean-Louis to end the session.
I concur with the first two.
In order to show the partners who bought, but also the government that invested, that it is a good opportunity, that it is a good beneficial aspect. Thank you very much. Thank you, Abena, for this moderation. That's a great. Thank you to Aurore, to Jiko. And this session allowed us to overview all the logistical challenges, financial challenges, but also human resources, equipment problems that we are all facing. But we agree that the digital tools helps improve and favor and sustain the health system. But it must be based on a national strategy in order to better organize and plan these intervention that could be done through an architectural company to set up a better integrated platform and to maintain and to monitor anything pertaining to regulation and train. A lot of comments were talking about the training, capacity building. We should do that. We should not omit the cost. This will allow us to align the objective that aims to reduce these illnesses, diseases such as malaria and other diseases. Thank you to all of you. Thank you, and have a great rest of conference.